Welcome back to those who've been there before, and welcome to any new ones. I don't know who, I can see somebody up there just working on the forearm with a bit of MLS. Go, okay, keep at it. Get rid of that pain. Right, today, low back. It's a very big area, really. It's back on the side of the back. No, it's a big area. There's an awful lot of things we can look at. I'm going to actually simplify it a little this week. I'm not really going to go on radicular symptoms, but there are so many things which will cause back pain. And I'm going to actually just go through the slides, which are a little bit Italianish. We'll go through those. Again, I think they show the bleeding obvious, which you'll all know about basic things about the low back. But keep those in mind, and then we'll look how we're going to treat the problems and the general problems that we have, the things we have in just about every single case of back pain, whether it's radicular or whether it's mechanical. And there's a couple of things which are there all the time. So, without further ado, I'm going to go straight into the slide. Right. Now, hopefully, you've got, Steve, give me a thumbs up if you can see the thing. Right, brilliant. Yeah. Treating lower back pain. Let's go. Okay, muscle contracture, it's going to be one of those things which is going to be involved with just about every form of back pain you've possibly got. It's just generally down to pain. Pain is muscle inhibitor. What generally happens with the pain, you'll get, it's a evolutionary thing, but the muscle will go into a spasm to try and protect that area. And all the muscles which are really being affected here are all your global mobilizers, your quadratus lumborum, your erector spinae, all those things. And because they shorten up and down, they contract down there like that, and they put an extra pressure on this spine. So it will affect every part of the body, your neck, your thoracic spine, your lumbar spine, and these are things which we've got to look at. So this is why they say here, treat with the global approach when treating the body-specific location. Always think global. I've said this every time I've spoken to you with the laser. It's fine for working on the pathology, but let's look at the sources of things which are keeping this going. Okay. Again, it comes back to the other thing. It's not really the pain. It's the causes of pain, and this is a big area which we've really got to look at. There is another little area which I'm going to discuss is really biomechanical, and that's very important. So what are the common conditions you have? Again, this is, I'm asking you to, teaching you to suck eggs. You know, disc conditions, sacroiliitis. Again, sacroiliitis, I'll come on to that in a second. Spondylolysis, spondylolysis, we'll go through the difference on that. You should know that. Facet joint syndrome, plain old osteoarthritis. Going back to the disc conditions, once we have that, if we have a herniation or protrusion, we're liable to get the radicular problems because the herniation will actually start putting pressure on the nerve root. That's how much we'll cover in the next session. Okay, disc conditions, basically, it's down to acute trauma or repetitive stress conditions, incorrect posture, mechanical alterations, muscle weakness, stiffness. These are all things which can lead to that problem. And I'll show you with my, my very basic system afterwards, when we go through the slides, exactly what's happening. Any level can be affected, usually L4, 5 or 5S1. 9% of all those cases are in that area. Symptoms, this is just so much more than this, but local pain at the spine level, muscle contracture, you got, what's he doing? Dermatome. Well, dermatome pain, you just check your myotomes. If you have a radicular problem, we're going to check the myotomes, we're going to check the dermatomes, and we're going to check the reflexes. Why? Because we've done a little investigation, but just by doing those things straight away, it can give us the exact level that we're really concentrating on. And we'll find it on palpation afterwards. Going on, disc conditions, all the different things. So you see at the top, a normal disc. Next one down, a slightly degenerative disc. We'll discuss this afterwards, why it's happening. we've got a slightly bulging disc here, a nice little bulge out there. And normally if we see that, we'll probably see some slight narrowing, probably usually on the front where the pressure's been coming down and it's bulging out the back. Here, we've got the herniation. Herniation, what's happened is the nucleus pulpus, just through a long time of degeneration and shearing forces on that disc, it's seeped out a little bit. And what happens is, it's just pressure is just given away and it pops out the back. And that's where we're going to get the radicular problems. As we get older, thinning discs, very important. All these things we can actually do stuff about. We can certainly help it an awful lot for pain with the MLS. But again, we've got to look at the causes of pain as well, and degenerative, okay? So, references, we don't need that. Sacroiliitis, it talks about here. Look, sacroiliitis, you've got some clinicians who will say, this is the condition, you know, this is causing pain. I'm not a big believer in sacroiliitis as a single condition. It just doesn't happen. It's always the result of something else. So it's very simply, the sacroiliitis is because the joint, which is there, this gliding joint, is just not moving. It's stuck, which is the same at any level of the spine. Generally, that will be the same problem. So it'll be a question of getting this thing moving again, stabilizing the pelvis in the correct position. It's usually you'll find there's a torsion with sacroiliitis, but I don't want to go on too much on that. Spondylolysis, spondylolysis. You can read all that if you want, but this is the pars and articularis, the little bits which are making up the edges of the intervertebral foramen where the nerve root goes through. And well, basically, it holds the two joints, the two vertebral bodies together by they meet at the facet joints. If you look at cricketers, 40% of cricketers, asymptomatic, were somewhat asymptomatic, some were symptomatic, but an awful lot asymptomatic, scanned the bowlers. And the bowlers, they have the spondylolysis because just this rotation and the power coming through is causing a fracture on the pars and articularis. It's a cause of pain, and it's something which we can deal with massively with a laser. But this is all about mechanical, getting the strength around there and making it get worse. With the spondylolysis, it's both sides, so you've always got the danger of a slippage of the vertebral forward, which will then could possibly, there's 1, 2, 3, or 4 grades. If you get up onto grade 4, you're really occluding that spinal, the vertebral column. So you might cause some real, I don't know, caudal equina symptoms, and that is a problem. And that's not something I would probably deal with. That's just going to go straight out to A&E. Facet joint syndrome. Always when you're doing your investigation, when you're looking at the people, we go through all the various movements, a flexion, extension. We'll probably do a quadrant on them, taking them back. But it's generally, straight away, you're going to notice if it's more facet or is it more disc based on movement. The forward flexion causing the pain, and they stop, you know, a quarter of the way and pain. That is going to be discogenic, okay? When they come back and they've got a problem there, that's facet joint, because the facets are sliding together and you've got some real sticking and irritation on there. So always just think about that when you're doing your investigations. Osteoarthritis, this is going to affect so many people because we are just getting, what we're talking about here is degeneration. This thing is getting old and a bit wrecked. And there's one thing which happens in all kinds of back pain, but it's a big part of this as well, which is the compression of the disc. You've got a very narrow disc, which is going to affect the facet joints, the position I'll show you in a minute. And these are things which have just got to be looked at, okay? Mobility, flexibility, massively important in any of these things. Lumbar spine pain, blah, blah, blah. What do? We do our usual tests: muscle strength, range of movement, hip position, iliac crest position. On your sacroiliitis, just check the ASIS and then the PSIS. If you'll see a torsion very quickly, and that is generally going to lead to a problem in that sacral, between the sacrum and the innominate bones. Hyperlordosis, hyperkyphosis, just look at the person, just see what the situation is. It'll give you a clue in what we're doing. Sciatic pain, what it's talking here really is about radicular pain. I get fed up with the word sciatic because it's so misused, but in this situation, if we're talking about radicular pain, yes, we've got problems on that sciatic nerve, at the nerve root generally, but there are other conditions which can cause a form of sciatica, such as piriformis syndrome, and I'll just cover something on that as well. So in a mechanical situation, always worth looking at this. This is about one of the tests. This is about well, it doesn't say here, but it's your Lazeg's test. Couple of tests. You should know all these tests. Don't worry, we're not covering that today. We're looking at something else. We're talking about treating. How do you treat it? Rest, taping, manual mobilizations, active range of movement exercises, strength exercises, stretching, and MLS as the major thing to try and get us back working as soon as we can. Global approach, I've told there's movement on here, but I can't see it. There's a couple of, I'm not going to go in these, but there's a couple of research papers which just basically show that laser with exercise is more effective than just the laser on its own, which again in turn is much more effective than not using it. Having got all those slides out the way fairly quickly, let's really start looking at the practical side of this. Now, I'm just going to get out of here. Okay, and we should be back in the room. Okay, what is the big problem we've got with the back? It's evolutionary. It's a big problem. I know it's a thing which is losing some fashion, but it'll come down to one major problem. It's core. Why am I talking about core? Well, look, if we take our spine is very much made up of the vertebral bodies and the discs. And the discs are very much like that. It is a sponge. It's hydrophilic. It tracks water. That's what it does. It should be nice and plump and like that. And we've got the disc, the vertebral body on top. Now we have a natural enemy to this straight away, which is Isaac Newton. Do you remember gravity? Yeah. So gravity is naturally just pushing us down here as well. We've got posture as well. If our posture is right down, we can get extra pressure on the front of the disc. But then we've got this big problem of the muscles around here. I talked about muscle contractures when you have the injuries because they shorten to try and stop the movement. But in fact, they're causing a bigger problem because it's all the global mobilizers which all orientate up and down. So they shorten and we get this pressure down there and it just makes it worse. The spine doesn't move. We try to get some movement, negative pressure in there, real big problem. That disc needs to be full of water. If you fill it with water and put it on a table, it's amazing. It stays like that. If you put pressure on it, okay, like that, the water all comes out, it dries out, and it stays like that. And you end up with a nasty thing like this. And then if you don't have anything to help you at all, anytime, but you just got your global muscles working, you've got shearing forces on it, which is sending messages of pain to the brain. The brain says terrible pain, sends messages back to all the global muscles around there. They shorten and makes it worse. It's a nasty thing, and that's why we have such a massive incidence of back pain in this country. Right. What is the answer? Well, the answer is really getting rid of the pain. This is where the laser comes in massively. But getting rid of the forces which are causing this, i.e. stop that crushing down there. We can't eliminate gravity, but just activating the transverse abdominis, the fibers go round like that, not up and down, and we can just get that activating before the globals come in. And this is a whole load of an extra session, which we can look at, but just get the idea. If you get the global muscles to come in first, crushes down. If you get the transverse abdominis to come in first, it offloads because it's coming around here and increasing interthoracic pressure from the sides, which there's a top and a bottom, your diaphragm and your pooing and peeing muscles, and it comes in there and it just offloads from the spine. So that is something which is very important. Posture is also increasingly important because there needs to be a slight S shape in the spine, but the big problem is that's where your spine should be. There's you can probably see there's a very slight little S shape in here. What you'll see on so many people have really tight flexors because they're sat down all day, and tissues adapt to stress as you put them under. If you're sat down, your hip flexors are really short. So when you stand up, what's happening is to stand with your legs straight, your spine is like that, okay? And then what's happening is it's really curved around here, which means there's huge amounts of pressure on the front of the disc. The facet joints are all stuck together, and this is where we're getting pain. And this is where you might get the herniation and cause the radicular problems. We have no herniation today. We're just going to look at some general conditions, and then we're going to start looking at how we can actually treat this with the laser. So, very, very quick coverage there, but let's go over to my, my model, and we're going to actually change the position here. And then we'll come back, we'll look at the settings we'll put on the laser and show you how to use that. But there's a couple of things I really want to show you first, very, very important. Whenever you get anybody with back pain, because I pretty much guarantee you, you'll see what I'm going to show you. Right, so I'm going to turn that around so you can probably still hear me. Okay. Let's see, we have our model here, the lovely Francis. No, don't go down the bed. They always want to get straight down on the bed, the patients. Have a look at them. We've gone through forward flexion, we've gone through extension, we've gone through a quadrant, we've done all sorts of stuff. Before I get them lie down to palpate and find out levels and to see if I do need to assess dermatomes, myotomes and reflexes, I'm doing this very simple thing. I say stand there, so you can see the patient there. Can you take a step further back? Right. Well, we should see the patient there. What I say to the patient, I say stand on one leg, okay? So I want to stand on one leg and try and get it straight down, so that's perfect, okay? And then ask that patient to do 3 mini squats, okay? Right, fine, okay. They should still be able to do this. Probably if they had a radicular pain, they couldn't do it on the bad leg, but they can certainly do it one side. Just do the other side as well, and come down. Okay, ooh, right, now see, okay. Right, now, what I've seen there, you can move away. If you can see me, this is a massive giveaway straight away. I've asked, can you see my belt? It's below the belly. I say stand on one leg like that and give me 2.5 squats. What you'll see on 9% of patients straight away is a contralateral hip drop, which we got there, and you see the knee coming in, there like that. This is all to try and stabilize the body so we don't fall over, okay? But what's happening is the contralateral hip drop and the femoral anteversion is telling me that this corset which they're wearing, the transverse abdominis, is not activating. And what is activating is all the global muscles and especially the hip abductors. And that will be another area which will really come across in back pain. Okay, what I should be saying is there's the belt. I should say, give me 3 squats. I should see the knee come over the toes. I should see the belt level stay exactly the same. What's the difference? The core is working on one and it's not the other. And therefore, if the core's not working, we're just going to crushing down. Right, let's get straight into some sort of treatment. Can we lie you down on your front, please? Okay. I'm not going to go through anything. I would do my palpation of the lobes of the spine, then see if we need to look at anything else. But we're just going to go straight to treating this person. Right, now, very important. We talk about the global approach. The global approach means all the surrounding tissues. Right, we know from that drop down there that the core isn't really working. So there'll be messages going to these global mobilizers. The one area which is always involved in this is the quadratus lumborum. Okay, so we'll have a look in there. Can I lift this up here? Okay, and I just want to turn that down there so we can get the top here. When we're, can you see that? Let's bring this around here. Make it a bit easier to see. Right, so we'll assess the spine, blah, blah, all the areas, and both sides, blah, blah, we find anything out there. No major problems on the spine, so where's this pain coming from? Right, next thing I'm going to look at straight away is going to go into the quadratus lumborum. So really, about an inch, 2 inches to the side of between L1 and 4, and just feel around here. And if I get a taut man, put a bit of pressure on there, and actually here, she's in good nick. There's not a problem on the quadratus lumborum, but you'll get them really, really sore in there, and that's telling me that there is a trigger point in there. We've got a lovely setting on this machine for working on trigger points. So that is trigger points in there, or there, either side. The other place to look at is when we're coming down, if we're dropping down like that and coming in, the hip abductors are overworking like crazy. And what you'll always find is if you come in over on the glute minimus or the glute medius. Right, I can already feel something here on the glute minimus. Right, is that a bit sore?
Ow, yes.
Yeah, ow. I don't know if you heard Francis say that was ow. That was brilliant, that. And we come on this side.
Ow.
Yeah, ow. I'm just going to taut band. Boing. It's like playing, it's like playing a tune on that thing. Boing, boing, boing. Let's move to the glute minimus. She's actually not too bad on the glute minimus. And again, on that side, not bad on the glute minimus. This is so important because I'll show you afterwards the very specific referral patterns of glute minimus or glute medius. Glute medius will refer pain around here and a bit down the butt. Glute minimus will refer into the butt and either down the back of the leg or down, right down the side of the leg, right down to the ankle. And it's often confused with some sciatic pain. It's very different because it's more widespread. Remember, radicular pain will be lanceating, it will be peripheralizing and centralizing, depending on what positions we're in, and it's different. So if you're a clinician who knows the stuff, you'll know the difference there. But this will always be involved in this situation. Right, so we know we've got trigger points. The other thing I'll often do is, can you turn over onto your back? What we talked about, we don't necessarily have the sciatic pain here, but what we probably do have is with that problem around the, I didn't check the piriformis, that's another one to have a look in, but piriformis hip abductors, the sciatic nerve is going all down that area. And you'll often find that if you tell them to do an active straight leg raise, it's not too impressive. Could you bring up one of those, like, bring the right leg up, okay? Okay, so what's that? That's, I've got the count at the wrong place, but it's probably about 70 degrees. And if we come up here, tighten it up, and then I do that, it tightens, yeah, so it really tightens up. So that is the limit, but we don't have a nerve root impingement in there, but we've got some real problems with this sciatic nerve coming down there. I don't want to do the other side, I don't want to waste time, it'll probably be exactly the same. A great little trick to do with this is glide that nerve. And what you've got to understand is that nerve, which is coming down the leg, when she lifts her leg actively, the muscles are all working around there and they're stopping that nerve gliding the way it should. So it's probably been caught. Now, just watch this. If we get the leg, and if I get my hand in here, and what I do is I distract that leg, pull it right down there, okay, and then this is completely passive for her. She's not doing anything. And then I lift this up, still lifting up here. Tell me when it gets tight, will you? Are you tight yet?
Yes.
Let's tighten out. Okay, well, we're massive here, okay? We've come huge ways up. Probably do 3 or 4 of those, and then get them to do the active straight leg raise, and you'll probably see a big difference. One won't have really done it yet. Well, actually, already a little bit. Already a little bit, straight away. It's quite amazing that, okay? Right, so we've started working globally around the body. What I would also do, if I'd seen that, I will use the laser probably down the back of the legs and into the butt muscles to really work on contractures to reduce tightness of those muscles. Let's go back to treating the patient for the first time with the laser. Okay, so let me get back to the settings on the screen. Francis, if you can get ready by getting onto your front. Right, so what we're going to do is we're going to get the laser here. I think that's the one. Right, here we've got the laser. And when you switch it on, this is the screen you get. We're going to put it on there. I've said this every time. If you've got the Charlie head as well on the system, you'll see this, the little handpiece down there, because we can actually use that and get settings on that. I'll just start off with just using this, or we can actually do completely different settings on the Charlie head and have the two things working at the same time. Fantastic, fantastic system. Okay, so I'm going out to one here. Right now, global approach. What we're going to do is we're going to say, look, we've got low back pain here. We've got a whole load of different things, but a lot of these might be very similar. What settings? But what we're going to say here, she doesn't have real arthritis here, but we've got some real lumbar pain, some general lumbar pain here. Okay. What we're going to do is we're going to look at that eventually. 700 hertz, 10 minutes. 100%, 6 points. So we'll go around the area which we felt was really bad. As I said, in this situation, her spine wasn't too bad. It was actually much more problems in the quadratus lumborum and the glute minimus. So global approach, we don't go on this first. That's the pathology. We go straight onto the scan. Okay, scan says 300 hertz, 8 minutes, 25%. Okay, I'm not going to go up here. I'm going to be more down here and probably into the top of the butt. We're going to scan around there. It's a lower problem here. Right, I'm going to leave it on the acute settings. When you first get this thing, this is set for a more acute situation. If I put this to chronic, this is just flared up. Okay, so we're saying it's an acute situation. Chronic, you can see the hertz go up, the intensity goes up. Now, this is probably subacute. I'm going to leave it on the acute thing here. Let's just go up very slightly on the hertz. I'm going to press on 300. I'm going to go 400. Press OK, and I'm just going to go to 50% intensity. This will all affect the amount of joules which are going into here. You'll see as well here. It's not giving me joules per square centimetre because I'm scanning around with this thing. So it's moving all the time, so it can't give me an exact figure of joules per square centimetre. Right, so what I'm going to do is I'm going to do that. I'm going to press start, but before I do, the most important thing is a class 4 laser. What we need to do is put our glasses on. Let me just change. Let me just press start. Put the glass on. I'll press start. The thing will flash 3 times, boom, boom, but it won't start properly until I press the button on it. Okay. Let's just change this camera, and we'll go on to this one. So we should see the patient there. Okay. Right now, so I don't do my back in. Let's just bring this up a bit. Okay, I think it's over here. Right, now, for modesty reasons, I'm not gonna pull my wife's shorts down because she wouldn't be happy about that. But I'm going to go into this area in the lower back and bring that up there. Let me just bring this down a tiny bit. But actually, I really want to get into these here and down here. This is what I really want to do on my scan. So I'm going to just now press the button here to get this thing going. You'll probably see the red light there. And then what we're going to do is we're just going to go up and down. I'm going to go over the shorts. Do not go over the shorts if you've got the patient. Just get the trousers down. Okay. But for the reasons I've given you, I'm going to come over that and across here. And I think it's an 8-minute scan. Okay, so nice longitudinal movements and then going across as well, transverse. And so on. And we just keep going. Okay. We're covering all these areas. Now this is going to go on for 8 minutes, I think. We haven't got time to waste just showing you that, but 8 minutes is really not too bad. I'm going to stop it. Okay. What we're going to do now is we're going to change this. Let me come back. We're going to work on the pathology. So I'm just going to come back onto the settings here. Okay. Right, that will just run down. As you can probably see, we've still got 6:46 left, okay? But it will stop, and it will stop automatically and go diddly and just stop, okay? We'll get to that. Right, we've done our scan. We want to go on the pathology now. So let's go on to what we say, just some lumbar pain. Now we've got some general pain around here. Because what I'm going to do for that QL and the hip abductors, I'm going to really get the trigger point segregate that. So just let's go some general stuff around the spine. Okay. Again, 700 hertz, 10 minutes, 100%, 6 points. Okay. So it's really quite a lot of power range. 18.32 joules per square centimeter. It's quite high. We're going to just say start, boom, and let's change the screen. Let's get back to the patient. Okay, and as I said, it doesn't start until you just press that button. You don't need to press. There are 6 points, 10 minutes, so it's going to be 1.5 minutes each spot. But we say the main pain, apart from the trigger points out here, is just really around this area. So don't follow the screen blindly, go to where the pain is and we work on that area. We just leave it on there for about 1.5 minutes and it will switch itself off automatically. The screen will go down to 5 points left and with 8.5 minutes left, okay? And you just go on all around this area, okay? And it will just stop itself. I'm going to stop it. And then move on to the next point around here. So we're going to do that. But let me just stop it again because this is, I said to you, was the very first time I've been treating the patient. So we're not sure about how much movement we can do or anything. If you remember when we talked about doing it globally, but the other thing is optical windows. We want to try and open up these areas as much as possible. Now, lying down just on the front here, we can get some work, especially on the muscular stuff. which will work very well. But I want to try and get into these joints. Now, let's say the problem is more on her left side, okay? Let's open up, we said it's L4, 5, 5S1. Let's open up these facet joints, okay? And let's open up the whole area and get in there and try and deliver some laser into that area. So what I'd say to the patient is, we'll get me into what we would really do is for a grade 5 manipulation. So if you turn onto your right hand side, okay, well done here. What we'll do, actually, I tell you what, let's just see if it manipulates. Do not if you're manipulation trained, do not do the manipulation on the very first treatment. I know chiropractors often they do that. Osteopaths probably might do that, I don't know, but chiropractors will do it. We don't, because we always check our severity, irritability and nature. If the irritability is high in any way, if we start manipulating it, then we're liable to irritate it further. On the second treatment, third treatment, then yes, we can look at that if we need to get some mobilization there. But I'm just going to see if this does mobilize in any way. So we're going to put that down there so you can see the patient. What I would do is, you might think this is getting very rough with the patient, but I try not to be too rough with them. Just relax as much as you can. Okay, let that leg go. I'm going to go. Okay, that's what I'm going to do. Pour up there a bit. Okay. You can leave your specs on. Give me your hands here. I'm just going to twist around. Now, what I'm doing here, I'm already opening up the this area which we're trying to get in here. What I want to do is hook that behind there. Let's just see if this does manipulate. What I'd like you to do, bring your head back a little bit. Could you grab this elbow with this hand? Great, brilliant. And I'm going to bring this down here. Up to there. L4, 5, always get to about at least 90 degrees on there. And let's bring over here. Right, take a big breath in and breathe out. Okay, there we are. Okay, nice little manipulation just in there, L4, 5. What we're going to do is we're going to leave you in this position here. Okay, you're right there. You comfy enough? And we're going to get right in here. So L4 here, 4, 5 in here, just on this side. So this is we're going to keep the settings exactly as they were. Leave my specs back on. Okay. L4, 4, 5 in here. Beautiful. Let's get in there. And we just on that. And we'll continue that until it stops. Can we see? Yeah. We've got it in there. And we've opened up that joint massively. So we're really getting in there. What you can get the patient even to do, if they're feeling up to it, but they can even just kick a little leg around there, which is just opening up a little bit more. So we're getting a little bit of rotation, ton of rotation, but it just opens up a tiny bit more as we're going in there. That's great. Okay, just relax back there. And that's going on. Okay. Stops itself automatically. You might have heard the beat there. And I move on to the next spot. Okay, fine, that's fine. Down here. And we'll start it again. And it'll so on. It'll go on for the next minute and a half until it's finished. Boom, and then it will stop itself. I'll just show you what I'm talking about here. Let's get back to the screen. This one. We're continuing here. And as you can probably see, because we stopped the side and messed around, 7 minutes 44 left, 5 points left. It's It's going to be 18.32 joules per square centimetre, but it's counting out all the joules as we go on. And it does this till we get to the end, and then it'll go, and it will just stop. Okay, we're back to here. Right. I still want to leave a minute to show you how using the Charlie head as well, but one thing, what we talked about here was the problem with the trigger points, particularly in the quadratus lumborum and the glute minimus, okay? An amazing little piece of equipment, this, the trigger points. What we're going to do is we're going to get off here. We're going to the back, and we're just going to press trigger points. Leave it on acute. By nature, they are acute. It's where part of the muscle stuck in a contraction, neurotransmitters blocked in the motor and plate, burning oxygen all the time, buildup of waste products. It's just going to refer pain, and they have very specific referral patterns. I'll show you in a minute on the computer. Okay, it's 100 hertz, 20 seconds, 25%. Let's leave it at that. Okay, just press start. And we'll just do the trigger points. Now again, depending what level we're at here with the patients, probably go back onto your front, Francis, onto your front. That's your back. Okay, so moving on to the front, I'll just get back to here. Okay, now, we could do this in prone, or we could actually also do it in sitting. We can just get it now. We can do anything we want. We can do movement in the sitting. I'll show you another thing about actually getting some active movement going when you do the treatment. Just let's do the trigger points very quickly. Okay, it's all ready to go. All you need to do is press the button here. We go back on here. We actually, do you know what? I'm going to leave this QL because there's nothing really bad there. I want to try this glute min here. It's sore. Right. And hopefully you can hear that little scream of pain. I'm going to get on here and I just press this, okay? So we've got this going, and then you see the way it's going now. I'm just right on that trigger point. And it's, as you remember, it's going to go on for 20 seconds, really not very long at all. So we just let that finish, it'll switch itself off, as you see. Now what we do is we go straight back in here. Still a bit sore in there. Is that less than it was? A little bit less, but it's still about there. We might have to do this 2, 3, maybe even 4 times. But I pretty much guarantee you this will actually reduce massively, because what it's doing is it's unloading the muscle, it's allowing it to free up, and we get elongation of the tissue, and the pain will naturally just go. Let's get back in there. What's that like? A bit better, honestly. Yeah. Okay, it is a bit better, okay. I'm actually feeling less of a lump on here, less of a chalk bag. Let's give it one more time. So we're just in there. But this is phenomenally effective. It works so well. Well, 20 seconds gone now. It's hardly any time. Right, what's that like?
That is quite a bit better.
Wait, can you say that for them?
Quite a bit better.
Quite a bit better. Okay. There you have it. That is, she is my wife, but no, it's truthful that. Anyway, look, that was great. It just shows you. Now we are running out of time. Let me just show you. We've got to treatment 3 or 4 now. Let's really get some active movement in here. So if you could come and sit on the side. The patient is coming back. Third, this full treatment. She's feeling so much better. Sorry, I'm going to have to lift that up, if that's okay. And what we're going to do is just bring that down a tiny bit. Okay. I'm going to go back to a pathology setting, let's say. Oh, sorry, I need to get you. Sorry, I keep on forgetting. This one. Okay, we should be on the screen. Right, the trigger point thing just works so well. Stop. Out of there. Right on here. Right, we're going to go back on that lumbar pain thing we talked about there. Okay, lumbar pain. We've got a few points around this lower spine which we want to work on. Again, we're going to leave that where it is. We're going to press start. We've got our specs on. Beautiful. We'll just change the computer back to here. Webcam 2. Right, okay, there we have the patient. So we've got the back there. Right, now, a couple of things you can do here. I'll have to go to the other side. We can just get them starting to move this area, which is really pretty stuck and not moving, just so that some posterior and anterior tilting. So can you, so like that, okay, well, that's perfect. And as we're treating this, let's get this in the area that we want to do. And we're getting some movement on that spine, which is perfect, okay? And we've got our 6 little points to do. That finishes, we do the next one, keep on going. And that one stops after another minute and a half. So keep on going. We start again. And so on. Let's just stop that. Or we can actually then also use it in a way of a little mini snag. So what I want you to do is I want you to come forward here and crunch down there, not into pain or anything like that, and then start coming back against it. I'll be putting some pressure in here. So, right, so off you go again. So we get that going, and then back up. And perfect. That's good. And then forward again. And back. And it stops. Keep on going. We're going to do the next bit. Okay. And back there. So you can probably see what's happening. We're getting this working on a sustained natural apophyseal glide. Okay, stop there. And we're getting some movement in that spine as we're delivering the laser, which the 2 widths of light, 808 nanometers and 905 nanometers, are doing, which are synchronized together, are doing an amazing effect of tissue repair by oxygenating the cells by creating ATP and filling the mitochondria of the cells with the ATP. Don't need these now. We've got the reduction of edema. We've got mechanical effects of moving the edema away. We've got the anti-inflammatory effects by getting the inflammatory proteins to bind on the anti-inflammatory proteins to bind onto the mitochondria and the ATP. And then at the same time, we're getting 905 nanometers of light centered at 25 watts, which is inhibiting pain pathways. So we get this synergistic effect, all 4 things working together, and it has a monumental effect. So as an adjunct to what we're doing, it is just incredible. But you have to be able to identify what the problems are and deal with them in the way. Now, there's another whole session to be talked about getting that, that core working, because if you can get that corset to come around, it's like a weightlift as well. If you can get that coming around there, it will just naturally offload from the spine. I often tell the patient, I say, look, there's your spine. There's a virtual body. There's a disc in there, a virtual body, disc, virtual body. The global mobilizers shorten up and down, so they're doing this to the spine, and you probably see it's not very stable, and it's really crushing all these bits together. But the transverse abdominis, the muscles go round. So if you get 3 fingers, just put it round your finger like that, and if I just hardly any pressure, I put a little bit of pressure on that, and you probably see the top of my fingers gone bright red. Well, it's gone bright red very simply because if you get those fibers coming around there like that, activating, what they're doing is they're pushing all these bits apart, taking the pressure off the disc. The only thing that stops your finger shooting off is the end of your finger. Up here, you've got up here you've got your diaphragm. The only thing that stops it squidging down is the rest of your hand. Down there, you've got your pooing and peeing muscles. So it's actually getting that working as well. And that's such an important thing because yes, we can reduce the pain. We can make things better with this, but I can pretty much guarantee you the person's going to come back in 8 months' time and say, oh, my back's gone again. And to which the first question is, where's it gone, mate? They always say, my back's gone. But anyway, so let's stop it coming back by working on these other things. Right now, just finally, God, I always overrun. Very finally, just let me just show you the trigger points I was talking about in particular, because they have very specific referral patterns. Right, quadratus lumborum here, just to the right or the left of the spinal column. The quadratus lumborum is coming down here, vertical muscles. Those trigger points, they will actually send some pain right around the top of the iliac crest. It can often cause some pain coming down into the groin and a bit lower in the butt. Very big one, often missed. It's not causing the real pain where the trigger points are, but these things very rarely do. So that's your quadratus lumborum. Let's have a look at your glute minimus. Massive one here, really very much round to the side. There's two areas, right around to the side or slightly further back, the trigger points of the glute minimus. You can see it's quite a big area of that muscle. If you come more in here, you're going to probably get pain in the butt and down the back of the leg to just below the top of the calf. If you go on this side further out into the butt, down the side of the leg and all the way down to the ankle. And just finally, the trigger points in the glute medius, which is just slightly further around. Got the glute minimus here, glute medius further around here, and it will cause pain into the butt and right around, right over the iliac crest, a bit into the area where the quadratus lumborum. The quadratus lumborum, weirdly enough, actually refers pain lower down into this area. And there's usually a combination of these trigger points. Right, I've gone on far too long. Hopefully that's been a bit of help to you. Are there any questions? Let me stop the share. Right. Any questions?
Thank you, Paul. Yes, there are. Can you hear me?
Yeah, I can hear you.
Yeah, there are. Thanks ever so much. Got some great questions, actually, so thank you, everybody. Thanks, Paul. Thanks, Francis. So let's move on to the questions. Okay. So thinking about the patient's modesty, obviously, is the laser less effective through clothing if there are circumstances where you needed to do that?
It's not going through clothing, okay?
Yeah.
You've got to bear the parts. The reason, look, in a physiotherapy clinic, we all know there's the relationship, physio is a contract physio patient. There are some times where we need to access parts of the body which they probably might normally want to do. Now, the only reason I brought modesty into it here, I don't know how many people are watching this. It could be a very popular thing and there could be 500 people watching. I think it's probably more likely about 20. But I don't want to get my wife's butt out for 20 people to watch. And she probably doesn't either. So, yeah, look, in the private setting, your patient will generally they will expect to have to reveal a bit of modesty. What I always do in situations like that is I'll have other towels all around. So I'll just reveal the area which we're on. And so that, to all intents and purposes, they're totally covered up, but they're just that little area on the hip abductors, which we're getting in there. So it should be fine. I mean, when you think about it, often, you know, with groin pain, we have to get right into the pubic symphysis. We don't have them all open here. I have towels everywhere, and I can get the laser into that pubic symphysis area, and they're happy about it. And if they're not, we've got the practice manager who can come in as a chaperone. So if you don't have a chaperone, you're going to have to say, look, you know, I understand your feelings entirely, and we can't go there, because the patient's consent is 100%. It's not negotiable. It's 100% important. That's what they say. They say what's allowed, and so on.
Great. No, it's good. Good, so there's no misunderstanding that the laser can work through clovens. That's great. Thank you, Paul. Moving on to the next question. Can you laser during dynamic or active movements?
So is there what?
Can you laser during the dynamic and active movements?
Well, yeah, as we showed you there, we're lasering there, just past it, you know, where you're talking about with the legs, straight leg raise?
I guess it was, yeah.
Yeah, it was. I wouldn't. That's just a very quick. I just wanted to add in something here. It's just quite a remarkable thing. And then I would actually laser straight out. That would take me, what, 1 minute to go 3 pulls out, up here, 3 little movements like that, back down. And then we turn them over, and then we get into the butt area and the top of the thigh, which will really loosen off all the muscles around there. See, the big problem is, those muscles are too tight, they're too active, and we need to release them, because what's happening is that nerve, you can imagine, through the muscles here, especially the piriformis, in 15% of the piriformis muscle, the sciatic nerve actually goes through the piriformis. 85, it's going around by it, but you've got all these other, the obturator, you've got the hip abductors, everything, like loads of muscles here. And if something's a bit overactive, this is not able to glide through there, and it's causing a problem. If we do it passively, we release the muscles completely, and then we pull the thing through, and then we go with our straight leg raise. It's fantastic, and then we can work on relaxing these muscles, because we've already pulled it through, so we've got more length on there, and then we release the muscles, and the benefits are just phenomenal.
Brilliant, thank you. A few more, the questions are coming in. Thank you, everybody. What is the scan phase for?
The scan phase is really to actually get photobiomodulation into all the surrounding tissues. Now, what we talked about, pathology global. What I've been talking about as well is not the pain. I've been talking about the source of pain. So I'm talking about biomechanical sources of pain, everything like that. But that causes contractures, it causes trigger points, it causes all sorts of stuff which are happening and in the surrounding muscles. If we work as clinicians just to focus on that pain, we're never going to get anywhere. Actually, I've said this before, it's probably quite a good business model, because they'll be coming back, you know, every 6 weeks saying, oh, the person's great, they always fix me. But what they don't realize is, in fact, you know nothing, because you're not sorting them out for good. And that's what we've got to do. So we sort out the global, we get photobiomodulation, which means we're getting activation, we're getting ATP into all these surrounding cells. We're getting increased vascularity, blood flow, more oxygenation to all the tissues that are around there, which is going to help. And then we move on to the pathology, where we've got the real problems, and it's slightly different settings, and we really work on the pain in that area. But you see, you must never, ever just think, as a clinician or even with the laser, that is the problem there. The problem is there at exactly L5S1. It's not. There's a whole world of stuff around there which needs to be sorted out, probably as a result of the problem at L5S1. So we can sort out L5S1, but if you don't sort out the problems which that has caused around there, it's going to come straight back. Guess why? All those muscles are probably in contraction. They're shortened like that, up and down, which is going to do what at L5S1, but bang, that. And so you're back to square one.
Brilliant, thank you. As discussed at the beginning, when working on loosening the glutes and the hamstrings, which setting on the laser would you be on?
You can actually just work on a muscle contraction. There is a muscle contraction setting on there. Or there's certainly on the Charlie head, but let me see if I can get back on there. Okay. Start. Yeah, muscle contraction. I've been looking at all muscle contraction. It's got something here, but going around the area in the muscle, the total muscle around the area which has got the problem, and there's probably a trigger point right in the center of there as well. So you can work the muscle contraction on there, reduce all the tightness around there, or in the back of the legs or so on. And then find some trigger points as well, and just for 20 seconds, just give them a go at the same time. What is that? The something on there is not too dissimilar. It's 5 minutes, 700 hertz, 50%. Okay, so you know, often if they're not too different, these settings, just use something, but you've got something there which actually says muscle contraction. So let's get back to me here.
Thanks, Paul.
I'm back. Okay.
Great. And palpation, soft tissue work. Would you do this before or after the laser? That's an interesting one. We get asked that a lot.
What was that? Sorry.
Would you do if you're doing when you're doing your palpation and soft tissue work? Do you do that before or after the laser? Well,
palpating, I presume you mean when I'm doing my investigation. I don't just get the patient in and laser them. I get the patient. I find out what's wrong with them. Okay. Is it facet joint? Is it discompression of the front? Is it a herniation? Is it what? So that is where we go through everything. So the laser's there is a tool which I'm going to use to help them when we find out. There's no point in me just, the person comes in with pain, well, I'm going to laser you. Well, look, you might have some success, but what are you treating? Know what you're treating. Find out what the problem is. That's why your palpation is needed. You know, we've got to work out what the problem is. Once we work out the problem is, then we can address the problem, okay? And the surrounding tissues, the global program. As I said, look, on any patient, if you just get them into a single leg drop, you will see 90% they're getting the contralateral hip drop, femoral anteversion, knee coming in. That is another problem which I've got to work on as well. But that's a long-term thing, because that's going to probably bring back, even if I sort everything out, it's going to probably bring back the problem again. So know everything about the patient, sort out the surrounding area, sort out the pathology itself, and actually sort out any biomechanical problems which will lead to a return of this problem in the future.
Brilliant, thank you. Okay, if an issue has recently happened and is chronic, how soon after issue happened could they come for laser treatments? Well,
if it's just happened, it's not going to be chronic. It's going to be acute. Okay. You know, we're talking really acute up to 1 or 2 weeks. Well, a week really in the super acute area. Then after that, we're in subacute. And technically, in our language, acute goes up to 3 months. Okay, it's after 3 months we call it chronic. Why do we call it chronic? Because chronic refers to this length of time. All tissues, if I break your femur, if I smash it into little bits with a massive sledgehammer, you'll be taken to the hospital, they'll put a rod in there, you might have an elisio around there, all sorts of stuff, but it's guaranteed in 12 weeks that will be healed. Okay, it might not have healed perfectly, and there might be other bits also of pain, but it will have healed. And that's what the acute refers to. Acute refers to tissue damage, okay? And there are repair processes. After 3 months, we call it chronic pain because there's pain still there, and that's due to something else, whether it's some electronic system gone wrong, or it hasn't healed as well. There might be some acute on the chronic. But basically, if, let's say you've had an acute injury, how long before you can see them? We could get some edema work going within 48 hours. I generally will not see a patient within 48 hours because if it's a tissue, if it's a muscle tissue tear, something like that, my rule, they might say, oh, terrible problem. I say, right, you ice it for 48 hours, 20 minutes on, 20 minutes off, 20 minutes on, 20 minutes off. Wake yourself up 3 times a night, ice it, 20 minutes on, 20 minutes off. That's if you're an elite athlete. But otherwise, generally in waking hours, 20 minutes on, 20 minutes off. After 48 hours, the bleeding will have stopped. We can sometimes say if there's still an awful lot of pain, try another 24 hours. But then really, generally, after 48 hours, you come in and I'll start sorting you out.